Good afternoon, everybody, and thank you very much for that introduction. So I am an intensivist, but I do a number of other things in my spare time. And I do have an interest in health, IT, in design of facilities, and healthcare funding and how money goes around in healthcare and healthcare billing is really something that I've done for the last decade, both at RPA and outside of RPA. And I'm very thankful actually for the college and for ANZICS for giving me this opportunity to talk about a topic that's, might come across initially as a little bit left field for a lot of you, especially trainees. Now, I did think a lot about how to structure this and how to phrase this. There's a lot of ground to cover, and we're not just going to talk about healthcare funding itself, but a number of other aspects that are relevant to you as either clinicians today who are in a job or people who are looking for a job. So I do apologise to those of you that are directors of units and know a lot more about some of this than I do, and I do apologise to the trainees where this might be a little bit too much. I hope there's a little bit in there for everybody. I do have a conflict of interest that I need to disclose. I run a billing company. We're not going to talk about my billing company, and I don't get paid for being here, but that's just for sake of full disclosure. So in terms of if you're sitting there wondering why we're talking about all of this today, there are a number of things that I would like you to hopefully take away from all of this. And one of those things is that healthcare is not a charity. So healthcare is a business, and you're part of that business, whether you like it or not. So having a big picture understanding of how that business flows, how the money goes in and out of it, how the hospitals get paid, how the units get paid, how you as a doctor get paid, that's actually very relevant, even if you just have an overview of that. I do want to talk a little bit about how you get in, how you work as an intensivist. It's not as straightforward as turning it to a job and getting paid, unfortunately. And getting paid, even when you do have a job, that's also another tricky topic that we might try to cover a little bit, just so we get your head around some of those things when you do get to that stage of your life. There are some responsibilities and liabilities that come with working in that system. And what I will try to convince you of, just very briefly at the end, is that this is actually a space where we do require people to be active, where there is education needed for all of us, whether we're a senior specialist or a very junior trainee, and how you can somehow be part of that. There are a few key objectives that I want to get through. I really just want you to appreciate that it's difficult, that it's complex, and look, it's going to be very similar to when we teach ultrasound courses. So we run one-day echo courses. We don't expect anybody to walk away from that knowing all about cardiac ultrasound. What I want people to walk away with is a general understanding that this is what it entails, this is what it is, and this is what I need to do to sort of get there. So I want you to give you a general idea. And to understand why it is important, if you're still wondering why the hell am I listening to all of this. And I'll give you some potential tools and resources where you can do that. So first of all, let's break this down into who pays for the patient admission, who pays for the hospital care. And we'll talk about the fundamentals of what universal health coverage means. We'll talk about how funding happens at a state level and federal level and how that interacts. We'll talk about public and private arrangements, because obviously we have both of those. Hospital costs versus medical costs, because there's two things, as weird as that sound, they're not actually the same. And we'll talk about what other sources of funding go actually into the patient care. What we probably won't talk about is how individual units get all of their funding and their money for their FTEs and things like that, because that's a more specific topic that's for leaders of units, and that'll probably be a bit beyond the discussion that we need to have today. Fun facts. So Australia didn't always have universal health coverage, whereas in Germany, even in the in the 1880s, they had universal sickness insurance, at least for their workers. Australia, even in the 1930s, we only really had the beginnings of what was private health. And 1 in 5 Australians had no health cover at all. So if you turned up to hospital, somebody was going to pay, and it's going to be you. The Commonwealth didn't actually have power to legislate about social services, so it took a referendum in the 1940s to allow the Commonwealth to do that, and then it took them another 30 years to come up with universal health coverage, which was back then called Medibank. It took not very long for that to be abolished when the next government came in, and then a little bit longer for that to come back in as rebranded Medicare in 1984, and it has been Medicare ever since then. Now, the big picture, if you look at the spending on healthcare in Australia is that these are ginormous numbers. So $250 billion or so, this is 22-23 data, spent on healthcare. And about 110 billion of that is actually spent on patients being in hospital. So this is a very, very large amount. And this is about 10% in Australia, 10% of our GDP. And if you look at other OECD countries, we think that this is a very huge stash of money that we're spending on this. But Australia, compared to how much the GDP is, actually isn't spending as much as some of the other countries. And obviously, the United States is a massive outlier, and their healthcare system is a complete mess, so we're not going to talk about that. Now, in terms of how funding happens for hospitals, so public hospitals, as you'd expect, it's state and government, so federal money, and we'll talk a little bit about how that actually flows to the hospitals for the largest amount, and then a very small percentage is picked up by either the patients or other insurers or the private health funds. For healthcare provided in the private hospitals, as you'd expect, the largest majority of that is covered by the health funds, but you also see that there's a significant proportion that's actually covered by the federal government via Medicare. And that proportion will be the subsidizing of medical fees or medical invoices, and we'll talk a little bit about how that works. So even in the private hospital, there's a lot of federal money that goes into that, and that actually funds how patients get treated. And as you'd expect, patients and other insurers pick up a little bit more of the check. Now, overall, if you look at the last 10 years, healthcare spending has gone up by an insane amount, I would say. So in about 10 years, it's almost time and a half, so gone up by almost 50% from 70-odd billion to, well over $100 billion a year. So a lot of money. Now, how does this work in practice? So universal health coverage scheme really is the umbrella notion that covers this. The Department of Health and Aging is really the institution that deals with all the policy and that actually oversees compliance as well. And Services Australia, which I'm sure you've heard of, is really the administrative body that sort of makes sure that Medicare works and people get paid and hospitals get paid. And this covers free treatment in a public hospital, and we'll talk about how the money flows for that. And it covers subsidized costs for doctors' invoices. And this is really all the medical care, so all the things that are listed in the medical benefit schedule. Now, it's not meant to cover all of it. It's a subsidy, and it sort of depends how much you get subsidized based on where the care is actually provided in hospital or out of hospital. There are a number of other branches of universal health coverage, which like the PBS and the DVA, Veterans Affairs, which also falls under the bracket, but they're not necessarily part of Medicare as such. Now, if you have worked in public hospitals, and especially if you have been involved in any sort of management level meetings, and again, I do apologize to anybody who actually manages a unit, and this sounds a very simplistic version of how things happen, but basically in Australia, public patient care gets funded under the National Health Reform Agreement, and it gets funded under a mechanism that's called activity-based funding. And the easiest way to get your head around activity-based funding is that basically every stereotypical hospital admission, so be that tonsillectomy or cardiothoracic surgery, patient goes to hospital and there is a made-up unit of acuity, resource intensity and effort investment into it, which is the NVAR, which is the National Weighted Activity Unit. And so every standardized admission has a number of NVARs attached. Obviously, if it's a small, not resource-intensive admission, it'll be a low number. If it's a very resource-intensive admission, it'll be a high number. But it's a number without meaning. So they have a separate body, which is the Independent Health and Aged Care Pricing Authority, which I have to read my cheat sheet because I can't ever remember, who sets the NEP, which is a National Efficient Price, and the National Efficient Price is what you get paid for one single NVAR. So the way this then happens is that the federal government and the state and territory governments look at the activity that the hospital does. So they look at what you've done last period, or last semester, or last financial year. They work out the case mix, they work out how many cardiothoracic surgeries have you done, how many hip replacements, what are you likely to do next time, or the next same time period, what's the exponential growth that you're expecting in your services, and based on that and the MRs and the NEPs, you get a bucket of money. All goes into something called the National Health Funding Pool, which is a fancy name for really just a number of bank accounts for every single state that sits somewhere in the Reserve Bank with really large balances. And there is some other forms around revenues of funding, which is called block funding, which is sort of for specialized services in specialized institutions where they actually need more money, that or different sorts of funding that could be captured under these instances, and some of that gets channeled through different avenues. But essentially, the large majority of payments go through the National Health Funding Pool, and from the National Health Funding Pool, the states then divide up the money between the hospitals. And the way that happens is they actually look at but they don't look at hospitals, they look at local health districts, and they look at the activity in the local health district, and then have annual or financial year service agreements with the local health districts, which works along roughly similar ideas of looking at what you've done last year, trying to predict how much you're going to do next year, and then giving you the money that's supposed to cover that. Now, that rarely ever works in practice because there's fluctuations, and we always end up doing more work every year than what we thought we were going to do. So if you've ever worked in a local health district, and if you've ever been to any meetings, you will hear that, that around the 28th of June, the local health district is going to be significantly in the red. Come 1st of July, it all goes back to zero and happy days again. So that's how, in a very, very simplified way, public funding works for public healthcare in Australia. Now, where does the rest of the money come from? So the rest of the money comes from private health insurers, so Medibank, Bupa, you name it, and they pay for the hospital side of admissions in private hospitals. They pay for the private admission, the hospital costs in public hospitals, plus they provide overseas visitors coverage, which works a little bit differently. There's obviously lots of insurance agencies involved, so people that get compensation claims, so workers' compensation, motor vehicle accidents, and other compensations claim, fancy things like the Dust Diseases Board, if anybody's heard of that, and overseas insurances, which roughly in terms of how they pay for the services provided work very similarly to how other insurance agencies do. And then obviously there's the patient, and invariably, even for some of the public admissions, there will be things that are not covered by Medicare or health funding, or if you're a private patient, there will be things that are not covered by your health fund. There may be a gap, so the patient ends up putting in a little bit of money as well. So if we look at what a hospital bill looks like, and I'm not sure what you would have said to this if I asked you this before showing you this picture, but it's only about 55% of the hospital bill which is actually spent on the hospital. So that's your hospital accommodation, which means it's your hospital room, it's the nurses, it's theatre time, it's stuff that happens in the hospital. There's probably 10 to 15% depending on what sort of problem you have in hospital, but in general 10 to 15% spent on prosthetics. So that's all the devices that get put into you, your knee replacements, your cardiac stents, your pacemakers, other things. There is a very small amount that gets spent on pharmaceuticals. Generally, if you're a public patient in a public hospital, most of it is free. And then some miscellaneous items. If you want to rent a TV in your room, then you're probably going to pay for that. But the other big chunk of this is really doctor's fees, so medical fees. And medical fees make up at least 1/3 of the funding that gets spent on healthcare in hospitals. Now, just to complicate matters a little bit, so in Australia, you can be a public patient or a private patient, and you can be in a public hospital or a private hospital. So if we look at just the two bigger chunks of that equation, so the hospital bill and the doctor's bill, and try to figure out who pays for them, well, it's not as simple as you might think. So let's take an easy one first. Public patient in a public hospital, you obviously have the funding arrangements that we talked about between state and federal governments who pay the hospital, and then the hospital pays the doctor. Even that's not all that straightforward, because you can be a doctor in many various ways in a public hospital as well, which we'll mention in a bit. But essentially you get paid by the hospital either a salary, or if you're a fee-for-service VMO, you itemize your services, but still the hospital is the entity that pays you. Now, if you want to be a private patient in a public hospital, well, first of all, why would you want to be a private patient in a public hospital? Well, if you want to go and see the surgeon that you want to see, or if you want to get a private room, most of the time those are sort of things that you can get out of using your private health insurance. And most of the public hospitals will waive any accommodation-related access and things like that. So usually they entice you to do that without being too much out of pocket. But who pays for the care that changes? So the private health insurer, so this is private health insurance for Australians. So the insurance company, so Bupa Medibank pays for your hospital accommodation, but still the federal government pays through Medicare for most of the medical services. So 75% rebate for medical services in hospital, so that's money that comes through the federal government, and that's outside of all the funding that usually goes into the public hospital, and that's important to understand because that's a very large chunk of the money that gets spent on healthcare in hospital. So it's a way of funneling in some more money through Medicare into the system that otherwise wouldn't have come into the system. And the patient usually bears a little bit of the cost if there's an excess involved from the accommodation side, and the doctors, which again we'll get to in a bit, can actually set their own fees in some instances, so the patient might actually be out of pocket a little bit in that regard as well, but the majority is covered basically by the health fund and Medicare. If you've got an insurer, so if it's a workers' comp claim, if it's some other private insurance claim, but not a health fund, then the insurance pays everything, including the doctor's bills and the hospital bill, and if there is any discrepancies, then the patient picks up the check. In terms of, I don't actually know all of the regulations in all the states, but in New South Wales, the amount that you can charge for a compensation claim, so workers' comp, for example, is determined by CIRA, which is the insurance authority in New South Wales. So you're not allowed to gap the patient on an insurance claim. They tell you that these are the rates you're going to charge. If it's another insurer, if it's somebody with an overseas travel insurance, of course, then you can just do whatever you want, and the insurance will either pay it or not, and the patient might end up with the rest of the bill. Whether you want to do that or not is a different question. If you're a self-funded private patient in a public hospital, so I'm sure many of you are asking, why the hell would you want to be a self-funded private patient in a public hospital when you can be a perfectly good public patient in a public hospital? So why? Well, the reasons are the same. So same as going in as a private patient with private health insurance. Actually, there are two reasons. One is that you can come in and you can see the surgeons that you want to see. So as a public patient, you don't get to pick your surgeon or your specialist. You come in and you get treated. If you break your hip, you come into hospital, whoever's on is going to do your operation. If you want to go and want to see Mr. Smith to do your hip replacement, but you don't have private health insurance and you can't go to the cushy private hospital down the road, then you can come in as a private patient, which means that you will be footing the bill for the hospital accommodation, all of it. Medicare will still pay for the doctor's bill, 75%, and you will be putting the rest of that. Yeah, let's have a look at what happens in the private hospital. As a surprise, you might find that public patients end up in private hospitals. This is really rare, and this only happens when the public system runs out of capacity. So if you've got long waiting lists and you're not meeting your set targets about people needing their operations within 3 months or 4 months or whatever, then sometimes rather than stocking up penalties, it's cheaper and most economical and better for the patients for that to be outsourced to a private facility. So the LHD pays the private facility, and the doctors and everybody gets paid really through that mechanism with a bit chipping from Medicare. This happens very frequently. The biggest volume that we've seen was really during COVID, when all the hospitals were overrun with sick patients, and a lot of the elective surgery was just farmed out to private hospitals. And it's sort of dragged on into post-COVID eras as well. So if you work in private hospitals, you might have seen public patients come across from completely different LHDs to have their surgeries done, which we've seen a lot of. But this is rare. The most common one is that you're a private patient in a private hospital, in which case the private health insurer picks up the tab for the hospital, Medicare picks up most of the tab for the doctor, and the patient pays whatever overheads that may be. If you've got a different insurer, then same as in a public hospital, the insurer will pick up the bill, and if you're not a compensation claim, those bills may exceed what your insurer actually covers. So if you're a tourist, for example, in which case the patient foots the bill. You can be a self-funded private patient in a private hospital as well. And the reasons to do that is really to have the cushy niceties of being in a private hospital. It happens a lot in maternity, and it happens with services that wouldn't be paid for anyway, like plastics. And this is people that don't have private health insurance but have the money, and they actually will then pay out of their own pockets for all of the hospital costs. The doctor's costs, if you're an Australian patient, regardless of how you get treated, is still 75% still comes from Medicare, no matter what. And the rest of it will have to be basically funded by the patients. All right. So that covers, in a nutshell, very quickly, about where the money comes from, depending on what sort of patient you are and what hospital you're in. Now we're going to get on to a second part of the talk, and a slightly different topic, which hopefully will be a little bit more relevant to those of you that are still looking for jobs. And 3 people woke up in the back. So what I want to touch on briefly is the forms of employment you can have in healthcare. So whether you're an employee or a contractor, what the methods of doing that is in public and private. And once you start getting paid for your services, how come the same thing has 5 or 10 or 20 different price tags? And you'll know what we're talking about when we get there. So take a public hospital first. So public hospital, you've essentially got 2 options. You're either an employee or a contractor. So if you're an employee, you're most often going to be called a staff specialist. Contracts, at least in New South Wales, they are either temporary or permanent. And I know that there is a lot of differences between New South Wales Health State Awards and other awards, and we definitely don't have the time to get into all of that. I don't know if Benny's going to be around. If you want to talk to somebody about in a bit more detail about the major differences between the awards, she'll be the person to talk to, because as I'm sure you know, there is a bit of discussion going on around this in New South Wales. But anyway, the New South Wales Award at the moment gives you nominal hours, which means you get paid for X hours per week, no matter what you do. You don't get any buildings or overtime or callback really. You get leave at super, and you get right of private practice, which means that some of the private work that comes through the hospital, not all of it, some of it, you get a portion of that paid to you as part of your salary. The other option in public hospitals is to be a VMO, and you can either be a sessional VMO or a fee-for-service VMO. Either way, you're going to be a contractor, you'll be appointed on a cycle, so usually in New South Wales it's a quinquennium, so it's a 5-year cycle, and then you have to reapply for your position. And if you're a sessional VMO, the short version is that you get paid the hours that you work, and if you're a fee-for-service VMO, you get paid basically for the services that you provide. And because you're working in a public hospital, the private billings, if you're a VMO, actually all of them go to you and they're your responsibility. And you're getting paid by the hospital for the public work that you provide. So if you're a sessional VMO, the way they get around that is if you're treating both public and private patients as you would, then you normally get a deduction of your hours. So intensive care is probably the most straightforward one. They'll give you a contract where they say you've got a 10-hour VMO shift, but you're only going to pay you 8 hours because you usually have a couple of private patients. If you're a fee-for-service VMO, which is very, very rarely done in intensive care, it's done more by the consulting and procedural specialties, you just bill everybody. And the public, so you just itemize your services, they don't pay you for hours, they pay you for services that you perform. And if you're a public patient, then the hospital pays the bill, and if you're a private patient, the private health fund pays the bill. All right, hopefully not too convoluted yet. If you're in a private hospital, believe it or not, you can actually be a specialist in some private hospitals. It's incredibly rare, and that contract will not be governed by any state award or any other protection. It will be whatever contract you get with the private entity, and so you may or may not get things like loadings and callbacks and access to private funding, and it's really rare, so we won't spend too much time on that. And otherwise, you're going to be a VMO. Now, if you're a VMO in a private hospital, there is no portion of work that you actually contract with the hospital to perform. So just think about that a little bit. So your services as the medical specialist really relate to medical services provided to the patient. So you bill your services straight to the insurers, so that Medicare and the private health insurance, or whoever is covering is paying for it. So you're not actually in any contractual relationship with the private hospital. You're accredited to turn up and perform work, but it's not the hospital that's paying. And if you do that as a VMO, you can either do that as an individual, or you can do it as a group where you can share your billings. There is another version of this where you subcontract it as a VMO to people that are VMOs in the hospital. where they say that, we're going to provide the ICU services, we'll make sure there's somebody on the roster, and we're going to give you a daily rate. I think that goes without saying that the daily rate you get given is usually either less or a lot less than what you're actually generating in private revenue. So you're actually just generating money for the rest of the people in the group. Other than that emoji down there, I'm not going to say anything else about that method. All right, so we've covered healthcare funding. We've covered how you're going to get employed, so we can all go and get a cocktail now. Unfortunately, not quite just yet. You've got to get through my fun facts first, again. And we're just going to talk about Medicare rebates a little bit, which then leads on to what we're going to discuss next. So, and I don't know if we still have our legal person in the room, but they can correct me if I say anything wrong. But in Australia, doctor-patient relationship is a private contract for services. So very much the same as if you get somebody to fix your TV or get the plumber to fix your plumbing. Practitioners can set their own fees. You heard me, practitioners can set their own fees, and the government is not allowed either directly or indirectly to influence how much you charge. And the best example of this is how they can't compel GPs to bulk bill. They can incentivize them, they can give them all sorts of extra money or extra perks, but they can't say that thou shalt bulk bill. It's up to the doctors. Medicare insures the patient, so it's an insurance scheme, and the Medicare rebate belongs to the patient. So it's not a payment insurance for your services, it's something that belongs to the patient, and they can assign that right to you if they so choose. And Medicare doesn't cover all of your services, and the rest of it needs to come from somewhere else. So where all of that is important is it helps in understanding this problem. So if you think about performing the exact same service, say you've intubated a patient or you've done a bronchoscopy, depending on where you work and depending on what environment that is or what the setup is, there are probably 20 different dollar values that intervention carries. And the reason for that is that although the rebate is always going to be the same, so down the bottom in blue is always 75%, but the health funds give you back vary depending on the scenario. So in the public, it's straightforward. They give you, so 75% Medicare, 25% health fund, you get 100% of the MBS rate for the services that goes into the bucket in the public hospital, that's fine. But in the private, you're allowed to charge whatever you want to charge. So the health funds want to incentivize doctors to not get the patients out of pocket, because obviously it's not a very sellable private health insurance if you tell the patient that you're paying thousands of dollars a year, but when you turn up to hospital, you're going to have a pretty hefty bill from everybody as well. So nobody wants that. So what they're going to say is, we're going to give you a higher rebate than what the MBS schedule fee is. So say if it's $100, we'll give you 120, 130, but you're not allowed to charge a gap. And those things are called no gap or gap cover arrangements. Or they're going to say, well, if you're really, really greedy and you really want some extra money and you're going to charge the patient, you're only allowed to charge them X amount of money, so up to $500 or $800, depending on the fund. And they're going to call that a known gap arrangement. That's a gap for the whole patient interaction, so it's not per service. It's for the whole invoice, for the whole entire admission that you deal with the patient. And what you're going to get is less of a rebate if that happens. Or if you're a star neurosurgeon and say, well, I've got patients lining up down the street, I'm going to charge an insane amount of money for surgery, the health fund still obliged to pay 25%, but then the rest of the bill will be picked up for the patient. And if the patient's self-funded, obviously there's no health fund involved, so whatever you're going to charge, above the 75% MBS rate is coming out of the patient's pocket. So I'm sure there are people sitting there thinking, well, this is awesome. This is the best thing I've ever heard. We're just going to gap everybody and goodbye student debts. Here's private island. Here we go. I would like to unfortunately put to you that that's probably not the thing that you should be thinking about. So there's a few things that go with charging people out-of-pocket expenses in intensive care or anywhere in medicine. And there's that pesky thing called informed financial consent, which should happen beforehand, ideally. It's also very, very difficult if you think about ICU to actually understand how long your patient's going to stay and what services you're going to provide. So I don't think that actually flies. If you do the maths, they also don't quite work, because it might be that you're better off charging a gap or out of pocket for a 2-day admission, but if that 2-day admission turns into a 2-month admission and you're getting a decreased rebate, well, you may be at a loss actually rather than a benefit. And I think the most important thing is really, I think, an ethical consideration. One is that really, I personally don't think ICU is a time in any patient's journey, even the elective ones, where you should be wanting to have financial discussions with anybody. And this would usually be not the patient, not even the patient, it would be a relative. And also, as I said before, private health cover is fundamentally really so that patients can choose where they want to have their surgery and where they want to have their care done by whom. And ICU is not one of those places. I have not yet seen a single private patient who's come to me and said, no, actually, I want to be treated by Dr. X or Dr. Y. They have a right to, but it's incredibly difficult to arrange. And then what happens if they come in on a Thursday and you hand over on Monday and the doctor that they don't like comes in on a Monday? So it doesn't happen. So ICU, they don't really get much benefit out of their private health insurance. And I would put to you that charging the gap, it's not that it's unheard of. There has been precedents, but I would put to you that it's not the way to go. It's also a pain in the butt because there's a lot of people that go with it. And if you look at the actual data, so this is from APRA, which is not APRA, it's APRA, which is the Prudential Regulatory Authority that looks after insurances and banks and things like that. If you look at that, this is all the specialties and all the fees they charge, and the blue bits are the gaps. You can see ICU doesn't charge any gaps at all. So ICU is 100% Medicare and fund rebate, so there's no patient out of pocket. I'm sure you can guess which ones the big blue lines are. It's ENT and plastics and a few other usual suspects. All right. So now you know that somebody's going to pay you. All you got to do is generate an invoice and write down on the invoice what you've done to the patient. Unfortunately, we're still not quite there yet because somehow the system needs to understand the work that you do and how that translates to payment. You can't just say, I've admitted a patient with a chest infection. That's how the public funding works because they'll have an MBAR, but doctors' services are not paid that way. So you have itemized services and each service carries a value that's determined. All right, so that's easy. We're just going to look at the MBS schedule and figure out what we need to bill. There's only about 6,000 item numbers in the MBS, so that's fine. The good news is we're not going to go through all that, and the good news is we're not going to talk about item numbers at all. But really, just to give you a gist of how it works, there's only about 60 that we really use in ICU, and they're broken down into daily management, which is looking after your patient, having them on dialysis, having them on a ventilator, monitoring their blood pressure, doing procedures to them, and then a few other various bits and pieces like consultations out of intensive care, or if you've got a qualification, then medical imaging that you might do. That adds to it, but the bulk of it is really only about 20 or 30 item numbers. So awesome. So now you can put your item numbers on your little invoice and send it off somewhere to get paid. Well, still not quite there yet. The problem that you're facing now is that although you might put your item numbers in, the MBS with its 6,000 items actually has very, very complicated rules and regulations around how items interact, how there are certain preconditions that need to be met, how items get put in. And Services Australia manages the system. And unless you know how to actually do all of that, your invoice is not going to get paid. So what do doctors do about this? Because I'm sure you're all sitting there asking, well, I'm sure those of you who are consultant know why you don't need to know all this. But I'm sure those of you that haven't actually worked as a specialist are sitting there asking, well, what the hell, I don't want to learn all this. And this is what doctors do. So doctors do your little invoice with your 4 little item numbers on it. And what they do is, if you're in the public, you obviously give it to the hospital. In New South Wales, you have to give it to the hospital, but in other states you can. The hospital does your invoicing for you, so happy days. If you're in the private, you find a billing agent, a company, a practice manager, secretary that does it for you. So you give it to them. Easy, done. And then what they do is they either use software, so they use a billing software, or they have to unfortunately resort to very old school things like writing emails and sending off those things that you put on the post or sitting on the phone and listening to elevator music for half an hour. And eventually they get to the payers. And the good thing about this is Services Australia actually operates something called Eclipse, which you might have heard of, which is basically the software interface between all of the billing software that the health services, that the hospitals, that everybody uses, and Medicare and the health funds. So most invoices go through there. Easy. The small proportion of invoices that are really a headache, they actually go through the insurances, and the patient obviously can't be part of that electronic system, but that's fine. We've got somebody to go and deal with that for you. Now, if you want to be really adventurous, you can actually bypass that and do it all yourself. I would suggest that that's not for the faint of heart, and why would you bother? So at the end of the day, all of that gets done, and finally, you are paid. Hooray. So the next thing I know that people are sitting there thinking is, well, I'm a specialist in a public hospital. This is completely irrelevant to me. Why would I want to know about this? Or I'm always going to have a specialist job. Hospital's going to do my billing. Why am I even going to care? Let me try to change your mind a little bit on that. And this is relevant, whether you're a specialist, whether you're a director, if you work, especially in public health. I think this is an important slide. So as a specialist, you figure out your billing. You're actually responsible for what goes on the invoice, whether you like it or not. You're the person that has to, in one way or another, magically appear the items on that invoice. Nobody's going to do that for you. That is your job. You can't ask your registrars, you can't ask your secretary, you should not ask your secretary. And even if you do, you're the one that has to sign off on it, because at the end of the day, you're all going to be responsible for the valid. So that's just a caveat to the side. But anyway, so you do your job, you generate your invoices. The problem with that is that actually the payment cycle of that it starts much sooner and ends much later. So the processes there are distinct time points when the patient comes into a hospital where there need to be distinct events. And there are multiple departments and multiple people involved in this, and it starts with the patient coming to hospital. So if the patient's not an elective patient, somebody needs to ask them, do you want to have private health insurance? Do you want to use it? Patients are sometimes too sick. They can come into a hospital and they can't elect because they're unconscious. You can't talk to them. Somebody needs to follow them up and figure out. Now, it's all good and well that you generate invoices. Somebody needs to tell you somehow which patients to generate invoices for. How are you going to know? Are you going to keep tabs of them? Are you going to try to learn all the, close to 3 or 4 dozen financial classes that New South Wales Health uses to admit patients in public hospitals? Or are you going to rely on a more or less capable secretary? And then you finally done your invoices, you send it off for processing. Somebody then needs to actually do the processing, which is the billing department in the hospital. And then they need to follow up on all the problems that get knocked back by the visit on the bridge. So invoice comes back, item doesn't pay, somebody needs to sort that out. And if you look at that, it becomes fairly obvious that at every step of that way, there is an opportunity to screw things up. So if the patient doesn't get asked when they come to hospital, if they don't get identified as a private patient later on, if you miss item numbers because you're doing your invoicing from a month ago in your ICU and you can't remember if you've intubated the patient, you can't really remember if they've had a blood transfusion, you can't be bothered to look it up on the EMR because it's painful, or you have a paper chart which is even more painful. So anyway, there's human error. You send it off to the billing department and they do the same. There's somebody who's typing in numbers, they'll mix things up, they'll miss a number, they'll type in something else, and then there'll be rejections. And they just don't have the manpower to follow them up, and nobody in your department's interested in at all. So why does this matter? It's not your fault, it's not your problem. Why should you care? Well, why you should care is this. And that is a graph showing the potential revenue in green, starting at 100%. So in an ideal world, when you come into hospital and everything goes splendidly, and 100% of the legitimate chargeable revenue goes back to the hospital into the pocket that you get paid from. And down the bottom in red is the percentage of that revenue that you can potentially lose by the screw up. So this is actually real audit data. So this is a real case. And you can see that although those red bars are not very high, some of them go up to as high as 20%. 20% is 1 in 5 patients that should have had an invoice that don't have an invoice or have an incorrect invoice. And if you look at your green bar, when you add up all those things, what you'll find is that your revenue actually goes down quite significantly compared to what would be legitimate. And if you look at that, obviously your role in this is very small. And yes, there'll be transcription errors and crappy EMRs and can't get the data, but the large majority is really outside of what we do. Now you might think, well, surely this is one completely disorganized, stupid hospital and people have to do better than this. That's what I always thought, but it's not actually the case. So if you look at health jurisdictions where doctors aren't actually involved in this, so they have even less of an incentive than us in New South Wales Health, where our paycheck is directly dependent on us making sure that this happens. So if you look at Queensland, for example, where doctors just can get a multiplier on their pay, and then the hospital sorts out all the billing. So when they looked at, that's over a decade, but that's $800 million that they should have billed. If you look at the same thing in WA, where they have similar arrangements, so the doctors get an additional amount of money on their pay rather than billing the patients. Well, there's zero incentive for anybody to do this correctly. So 20 million, that's over a year. So there's a significant gap in there. And I would put to you that New South Wales Health is probably even worse. And I would also put to you that ICU, because of our electronic records and other things, we're actually better than most of the physicians and most of the other specialties. And this is, I think this is very important. And I always feel like I'm the only person that this strikes as completely insane when here we are listening to a news article or reading a news article or listening to the news every single day about how there isn't money for this, there isn't money for that, there isn't money for that, and all the local health districts are bleeding millions of dollars. And yes, some of that is your pay, but again, if you're a bit more involved in the mechanistical side of how that works, well, in New South Wales at least, and again, we won't go through the specialist award because that's a completely different discussion, but in New South Wales Health, basically, the more money, more private money comes in, the higher level you are, which is directly a saving to the hospital, not just in facility fees that they charge, but they subsidize your income by less. So you're going up a level, is $20,000 to $30,000 in savings for the hospital. If you're in a big department that's got 20 specialties, that's $500,000 a year, so it's a significant amount of money. All right, that's the last I'm going to talk about money, so we're all finished. The only other thing I wanted to mention, and again, this is one of my little bugbears that I keep going on and on and on about when people talk to me about this, is who's responsible for mistakes, who's responsible for problems. And just stepping back a bit, so administration and oversight of your Medicare claims is done by the Department of Health. And the abbreviation down the bottom, PSR, is the Professional Services Review Scheme. And it's one of those abbreviations that, along with the HCCC and APRA, is on your short list of abbreviations or entities where you never want to get a phone call or a letter from. But they're essentially the regulatory body that mines the data, so they have data of all of the claims that go through Medicare, and they look at anomalies. So they're very good at looking at big data and picking out patterns. So if you tend to bill 3 times as many lumbar punctures as anybody else in the country, they're probably going to ask you how that happens and why that happens and whether it's legitimate. And the reason for that is that the compliance doesn't only relate to being compliant in submitting in the item numbers in a correct fashion for the system to process it. The system's not perfect. And there are some preconditions that need to be met. So all the services that you provide, they need to be reasonably expected and appropriate services for the patient. So you might bill completely normally in a very legitimate fashion, and the system might pay you. If they then look at it and go, well, your service wasn't actually required, it wasn't the standard of care, you're going to be in hot water. Now, if you look at the PSR publishes monthly reviews of all the decisions and all the cases that they've looked at, if you look at that, well, you'll find that mostly it's GPs, and very rarely specialists, and mostly it's anesthetists. So I haven't yet seen an intensive care specialist end up in a PSR review, but that's not to say that it's never going to happen. And the argy-bargy that goes on about this, especially with regards to the physicians, is, well, who's responsible? So ultimately, the doctor's responsible for the claims. And you're going to be brought before the review panel, and you're going to, at best, have to pay back a huge amount of money. At worst, there's going to be much more significant implications. But who's responsible for teaching you? There is zero information out there. I mean, the stuff that I told you now, That's sort of 10 years of me picking up things as I go along, and a few odd courses here and there that you can do. But there's no formal education. There is no body that provides that education. There's no credentialing, and then people go round and round and say, well, it should be the colleges, it should be the societies, it should be Medicare, it should be the medical schools, it should be your employer, but nobody's willing to do it. So I think, unfortunately, at the end of the day, what I'm trying to say with that is that because the responsibility, both financially and legally, is on you, unfortunately, the responsibility to know more in this space and to educate yourself is also on you. So that's the bad news on there. Now we're getting towards the end. And what I would like you to, what you do with all this, well, you can choose option A and go, I'm really relieved that this is finished. This is the worst 45 minutes of my life. I'm going to go and have a beer somewhere. Even if you're going to do that, please take away at least a few things from this, which is just understand that it's business. It's not a charity. We're part of a business. Business runs as a business, which means that you need to recognize how you fit into that system and what opportunities and obligations and risks come with that. And for those of you that don't actually have a job as an intensive care specialist yet, but are likely to have a job hopefully very soon, I hope that I've given you a little bit of a taster of at least what sort of employment options there are and of the million ways that you can get paid. And this all might sound very trivial, but when I started first working as an intensive care specialist, I had no idea. I probably turned up to the VMO job that I was doing for about a month before somebody told me that I need to bill patients, otherwise I'm not going to get paid. I'm not kidding. And there's zero information out there. And so you've got to fend for yourself. So I hope I've given you a little bit of a taste. But what I would really like is this side of the equation. So what I would like you to do is to take away that this is an important area. And I do feel a bit like a one-man army trying to fight this battle or fight for this cause. But I think if you feel that it's important, it's very powerful when people get involved. And all you need to do is advocate, whenever somebody asks the question, whether you would want to know about this, whether you think, there should be more resources for this, it's important to you. I think it's very important to engage with any sort of transformation of systems or initiatives because, whenever colleges or whenever societies look at, revising their guidelines, revising their curriculum, that is your opportunity to then go, well, in fact, I think, it'd be very nice if CICM had a course on this. It would be very nice if ANZICS had a course on this. Somebody had a course on this. And I think it's also important to have, if you have some knowledge in this space, and as I said, some of you will have a lot more knowledge about the actual intricacies of how the funding gets channeled within the hospitals once it gets there from the LHDs, and then how it gets allocated to the individual departments and how it goes towards staffing and other things and all the battles that you have to fight day in, day out. You have that extra 0.5 FTE to cover the roster. It's very important if you have that sort of knowledge, first-hand knowledge, to be involved in any transformation of systems. And the SVPR, for those of you that don't know, it's the New South Wales Health Single Digital Patient Record, which is getting an enormous amount of work put into it. But there's only a limited amount of people, and you can only know what you know. The unknown unknowns never get noticed. So unless you speak up and unless you provide input, they won't have the opportunity to fix it. And I think if we don't take the opportunity to be part of that process, we're building a whole new system. If we don't try to fix all the gaps in the public hospitals where we're bleeding money left, right, centre because our systems are so bad, and there's never mind what's happening on the wards with the physicians because that's even worse. There's a huge, huge missed opportunity cost in there. So I would like, not all of you, but at least some of you to try to put on that cape and try to advocate for us so that the next system that we build will be better. All right, so that brings me to the end of the talk. I want to give you a few little QR codes. I'm very happy to talk to people, and the easiest way is to find me on LinkedIn. If those of you that are not on LinkedIn, please go on LinkedIn. It's probably the least worst social media platform, and you can actually connect with people and maybe find out about jobs, and the spam can be kept to minimal. If you can't find me there, the other thing, we're doing is I'm trying to, and again, this is really in its infancy, but I'm trying to build an online repository of information. And what I need you to do is actually try to engage and come to these things and tell me what sort of questions you have. So that's the easiest way to build content. So we're actually doing a monthly, completely free Q&A. Next one's on 30th of September. Shameless self-promotion. You can come and join. It's completely free, and you can ask whatever you want, and I'll try to answer. We're also doing a knowledge base online, which again is completely free, and it covers all the intricacies of all the items and how items interact and how you can actually generate invoices in ICU. Completely free resource. Have a read. See if you like it. See if you don't. Engagement's really important. I'm hoping that I'm not the only one in this space, and other people feel this is important. But I can't really build all this without people actually providing some input and telling me what you want to hear. And with that really is the end of the talk. And thank you very much for the invite, and thank you for putting up with me.